gang, and welcome to our next installment in our Advanced Cardiovascular Disease Management course. And in this discussion, we're going to talk about a disease entity that you will deal with a lot. You probably have already dealt with a lot, and that is septic shock. And this for this module, the if you haven't figured it out already, the second part of your care plan relates to septic shock. So hopefully this information will help you develop a good care plan there. And our discussion forum for this week is relevant to this as well, as we're going to be talking about early goal-directed therapy. So the latter part of this talk will give you a lot of information that will help you basically keep that in context and understand the various things that you can talk about relative to that. I'd make a really big point about early goal-directed therapy of septic shock because, as we're going to talk about in this discussion, you'll see that one of the earliest signs of this is respiratory rate goes up. It's part of a quick SOFA, which we'll talk about. And very, very commonly, the respiratory therapist might be the first critical care type individual called to the bedside of somebody with evolving septic shock because the SATs drop. And so you might be the person that can recognize that early and begin intervention. And in a lot of hospitals, they've gone to programs of basically early recognition and management. They even have called code sepsis in some places that initiates a process that gets patients taken care of promptly. Because if you can get on top of sepsis and treat it promptly and early and maintain perfusion, then you can markedly decrease mortality. And we'll talk about that. That'll be basically the second half of this talk. So what we're going to talk about here, we're going to go through the basics of sepsis, the pathophysiology, because you really need to understand that pathophysiology to understand how you're going to diagnose it as well as how you're going to treat it. And then we'll talk about the basic management and things that have worked and things that haven't worked over the years. So real important topic for all of us who take care of these kinds of patients. So I'm going to go ahead and turn off my little camera thingy and get started here with our talk. So again, septic shock is the topic, and it's me talking, so here we are. The objectives, after you view this video lecture, it's hoping that you'll be able to define what septic shock is and the criteria for diagnosis. And these things have changed in the past few years, so we're going to give you the updated information. Apply the SOFA score and the quick SOFA score, determining severity of septic shock, which really translates into, who's going to need intubation, mechanical ventilation, who's going to need to be transferred to the intensive care unit, who do we need to talk to the family about hypertension mortality rates. We'll talk about the pathophysiology of septic shock. And then, as I say, we're going to talk about early goal-directed therapy, which has had a storied past over the past 15 years. And we'll get into the details of that. So sepsis is huge. It's probably, if we calculated the mortality, it's probably third after cardiovascular disease and cancer for causes of death in the United States, and actually for both of those disease processes, it's sometimes the ultimate cause of death. Any individual case, and we'll talk about it, once somebody evolves into septic shock, they don't get better in a hurry, and so they're in the intensive care unit on mechanical ventilation for a significant period of time. The cost is huge. Mortality, in spite of all the things we've done and all the things we've tried since I first started taking care of septic shock 40 years ago, the mortality rate has not budged much. It's budged a little bit. It used to be 40 or 50%. We're down now to 25 or 30% if you're doing a good job, but it's still got a very high mortality rate. And one thing that's important to consider is that sepsis is a final common pathway of lots of different kind of infectious processes. And the sepsis that we see in the medical intensive care unit population is different than that we see in the surgical intensive care population. Usually in the surgical intensive care population, the cause, the etiology, the infection is easier to identify, easier to culture the bug, and get the appropriate treatment on board, or drain the pus. In the MICU, it's much more subtle and indolent, and our patients have a lot of comorbidities that may inhibit their normal immune response. And so the mortality tends to be much higher in the MICU population. So you do have to look at that when you're looking at studies of sepsis and comparing, a study and seeing whether it's applicable in your environment. The PICO, we come back to the PICO all the time, right? So the patient population, if it's a medical intensive care, medical sepsis, it's a very different animal than surgical sepsis. You can count on for most of these patients are going to be in the ICU for at least a week, and hospital stays are frequently over months. So big deal. The Society of Critical Care Medicine and the European Society of Intensive Care Medicine, so that's the American, basically, although SCCM is pretty international, but that's the American and the European Sepsis 3 Consensus Conference published their outcomes in 2016, and this material is in your articles for review in Blackboard for this module. We used to, if you've been around for a while, you probably remember being taught about SIRS, S-I-R-S, as the systemic inflammatory response syndrome. We pretty much came to understand that that wasn't a very helpful definition of anything. One of the important things we have to do in research for things like septic shock is to be able to define it so that when we're doing a study, we're comparing apples to apples and not apples to oranges. And so that's the whole reason why the SCCM, ESICM came together to put together a functional definition of septic shock that can help researchers sort of compare and combine for multi-center trials. So SIRS is out. The new definition of sepsis is it's a life-threatening organ dysfunction caused by a dysregulated host response to infection. That's sepsis. And we'll talk about the variety of the host responses. So just to sort of set the stage, you take that 18-year-old who's got meningitis or an acute pneumonia, and that response, he's got an aggressive immune response. There's much more of an intense inflammatory response on the part of that patient. But generally they survive better, even though they have more of an intense response. You take a diabetic patient with renal insufficiency and congestive heart failure, and their response to infection may be much less effective, more indolent, and we'll talk about that because it's an important distinction to understand. So sepsis, that's the general term. That's the bigger umbrella, if you will, of life-threatening organ dysfunction caused by dysregulated host response. Septic shock is a subset of that. And it's a subset of that in which there's hypotension, basically. So it's in which there's underlying circulatory and cellular metabolic abnormalities that are profound enough to increase mortality. And, and the hallmark of the shock part of it is the hypotension that goes along with it. The key concepts of sepsis, which you see described on the right, are basically the recognition that early treatment can change outcomes, that sepsis in and of itself and septic shock relate to a combination of the pathogen that's causing the infection, be it a bacterium, a virus, or a fungus, that's initiating the inflammatory response, and then the inflammatory response of the patient. So we have a mix, if you will, a balance between these two things that creates the ultimate clinical syndrome that we see. The organ dysfunction in sepsis can be hidden or occult, but very commonly it's pretty obvious when septic shock is evolving. So those are the key sort of changes in our mindset as we approach the concept of septic shock that are important for you to understand. So again, this is really just a restatement of what I've talked about already, but we're introducing another concept here. So these are the definitions, as you can see. Sepsis is that life-threatening organ dysfunction caused by a dysregulated host response, and septic shock is that subset of that which results in circulatory, i.e. hypotension, and cellular metabolic abnormalities, i.e. lactic acidosis, that are associated with an increased mortality. Sepsis is a multi-organ system disease, and that's what that SOFA score that you see on the right is all about. So we can grade the severity of sepsis using a scoring system, and in the SOFA system, that's a system that has 0 to 4 points in 6 different categories, and the categories relate to organs that are impacted: respiratory, circulatory, hepatic, coagulopathic, renal, etc. So there's the impact on various organ systems that contribute to that. I'll show you a slide that shows you that SOFA score in a minute. It's a little cumbersome, so people use a quick SOFA score, which when you're in your rapid response, that quick SOFA, you can tell you 3 things, and it has to do with respiratory rate, mental status, and hypotension. That can tell you that patient needs to go to the unit, and that's really the whole idea behind the SOFA score and the quick SOFA score is assessing severity so that we get the patient in an environment that can provide the care they need. Pardon me. So here's our SOFA score. Again, as you see, it's a scale from 0 to 4 with respiratory system coagulation, and it's primarily platelets. And by the way, respiratory, it's primarily the PaO2 FiO2 ratio. For coagulation, it has to do with platelet count. For liver, it's based on bilirubin. For cardiovascular, it's the degree of hypotension or hemodynamic support required. For the CNS, we use the Glasgow Coma Scale, which, as you know, goes from 0 to 15, and is based on response and of the patient. And then renal, we do it primarily based on creatinine. So you can see that, this category obviously here is relatively normal numbers, and it's a gradually increasing scale, as you would expect. I think it's really important for us, you need to know what it is, because you'll hear people talk about the SOFA score. But it's relatively complex, and when you get right down to it in terms of septic shock, we talk about being 2 and above is going to get you in the unit. Well, the reality is, if you look at these numbers, that would apply to an awful lot of patients. So in terms of separating low risk from high risk, pretty much everybody on a SOFA score winds up being relatively high risk because of the scale itself. But it's important from a pathophysiologic point of view for you to understand that sepsis impairs the O2 gradient. And that's by virtue of the fact that if you stir up an inflammatory response in the blood, that blood hits the pulmonary circulation first. So the alveolar capillary membrane is one of the first organs hit, if you will, in full force by the evolving sepsis. Coagulation, platelet consumption is a factor. So we look at the platelet count and for that. For the gastrointestinal impact, we look at the liver and bilirubin, but that's only because we don't really have good indicators of gut perfusion. But that gut perfusion issue, like we talked about in our circulatory shock lecture, is a really important part of the overall process. Cardiovascular has to do with hypotension and support, so it's pretty easy to see that gradations of that scale. Same with the Glasgow Coma score. So you got a pretty unresponsive patient at this end. Patients responding, but maybe have a little bit of a depressed level, and then gradually increasing. And then our creatinine level. Typically, they're going to have this first. If you look for it, the platelet counts track pretty early as well. Cardiovascular is pretty early, and central nervous system effects are pretty early. Renal and liver effects tend to lag. So they're usually something that evolves more in the second or third day. So the quick SOFA, and this is obviously because the last scale is pretty complicated, right? And when you're on a rapid response team, you want something that you can remember and quickly use to assess. Sorry, when I do this at my office, it jumps ahead. So the quick SOFA has to do with the respiratory rate, and that's really reflects the impact of As we get that early alveolar capillary leak and a little edema in the lung, the lung compliance decreases a little bit. Remember, we talked in CP Phys about how when compliance decreases, respiratory rate goes up. That's the whole reason we do an RSBI. And so respiratory rate's an early indicator. And that's why you're very commonly the first person at the bedside that could recognize that this patient is in the process of evolving septic shock. You talk to them and you see altered mentation. That can be agitation early, confusion, and then increasing levels of depressed consciousness above that, and then systolic hypotension. Generally, if you've got all of these three things together, you've got a patient that needs to be in the ICU and needs a team that's turned on to the idea of early goal-directed therapy. So the microbiology, you would think that there would be a big difference, in terms of, sepsis from bacteria like gram-negative organisms or gram-positive organisms like meningococcal infection or the viral or fungal. The reality is, I think bacterial, you could generally say, induces a little bit more of an intense response. But if any of you have taken care of a really bad viral pneumonia, you know that can be pretty nasty as well. Fungal organisms usually tend to be in patients with depressed immune systems. So the inflammatory response in that setting is usually a little bit more muted. But you couldn't guess the bug from looking at the patient. That's my point. So you can expect, an inflammatory response in this multi-organ system response we talked about in the SOFA from any microbe. It's important, that last little bullet point is important, to know your local bugs. Your environment, particularly for hospital-acquired infections, but also your environment if you're, in the Southwest and exposed to, microbes that are different from the Northeast of the United States. It's important to know your local bugs because that can help you get a head start on the appropriate antimicrobial therapy and recognizing early what your infecting organism is, because that makes a difference in terms of what you can do. Whether it's the targeted antibacterial therapy, aminoglycosides or cephalosporins, or whichever the fluoroquinolones you might choose, or whether you're in the midst of a flu epidemic in your environment, so you might want to start something like Tamiflu or something along those lines earlier to mitigate the course of the disease. And same with the patients at risk for fungal infections. They're usually pretty apparent by virtue of being immunosuppressed in one form or another. All right, now I want to make a point that, and I've included this article among our articles in Blackboard. Rich Hotchkiss was a fellow with me at Mass General Hospital many moons ago, and he became a very academic anesthesia critical care person who got very involved in septic shock and ARDS. By the way, he's done a lot of the work which shows how the connective tissue proteins of the lung, the collagen and elastin, are damaged early and with positive pressure ventilation and ARDS. But he's also done a lot of work in septic shock in the lab and worked out some of the pro-inflammatory and anti-inflammatory components. And so this article, it's kind of dated now, but it's a really good read in terms of understanding in general terms. Nobody's going to expect, I as an anesthesiologist, this is above me in many ways. I think it's important though to understand some basic concepts, and that is we have pro-inflammatory and anti-inflammatory components, both cellular components as you see on this slide, as well as cytokines that are involved. So interleukins 1, 6, and 13 are really inflammatory. Some of the even numbered ones not so much. So it's important to understand the pro-inflammatory cytokines and the anti-inflammatory cytokines and their effect on various cellular elements, whether it's T cells, macrophages, neutrophils, or dendritic cells, which don't get a lot of attention, but they're tissue-based cells that sense invasion and can up or down regulate the response in sepsis. This is work which talks about the microcirculation in sepsis. And remember, we talked about in circulatory shock lecture that in septic shock, what we really see is a shunting of blood, so that blood flows through large connectors between the arterioles and the venules and never really gets to the tissue. So we have a setting where we've got increased cardiac output, but we've got decreased tissue O2 delivery and lactic acidosis and tissue anoxia taking place. And so the microcirculation is where a lot of this happens. And there's some pretty good live videos that you can just do microcirculation and sepsis in Google and go to the YouTube's the videos, and you'll see a couple of these that are out there that show literally show the flow. And I like this little graphic from Rich Hotchkiss's article, which addresses this. And at the top is relatively normal. And this is a technology that came out 35 years ago. I was using it in some early studies in anesthesia. And it basically, you put it on the mucosa of the gum, actually the inside of the mouth, and look at the literally magnify the microcirculation, and you can see the blood flowing. It's really pretty amazing. It really never caught on as a diagnostic tool, but it's one of those really cool things to look at. Not like echo, which is a cool thing to look at, which did become really useful. This never really got all that useful, but at the top we see relatively normal. So you see arterioles, capillary flow in the capillary bed, and venules. And if you were to see this live, you'd actually literally see flow. And down below here, we see the sluggish flow in the capillary bed. So you've got these large connecting vessels that go directly from the arterial to the venial, and yet and yet we don't, dang, nibbly. You can actually literally see the individual red blood cells because the flow is so sluggish in this setting. With this, we see capillary leak. We see loss of the glycocalyx. Remember, the glycocalyx are mucoproteins that extend from the endothelium into the small blood vessels that increase the oncotic forces and hold fluids in the vascular space. So when we lose the glycocalyx and we have a capillary leak, that really accelerates the loss of fluid from the vascular space into the interstitium. We also expose tissue factor that results in activation of coagulation and disseminated small vessel aggregation or clotting that takes place. So Rich Hotchkiss did this work where he looked at immune function in the trauma septic patient, the trauma patient versus a patient in sepsis. And what these two graphics show is, on the left is the trauma patient. So that's a patient with a normal immune system that's having a relatively, with all these positive dots and all this positive sort of coppery staining here has to do with the presence of dendritic cells, those cells that modulate inflammatory response. And they're relatively normal in the trauma patient. But notice this is a septic patient, but it's a septic patient with multi-organ system dysfunction, diabetes, so impaired immune response. And you can see there's much less intense immune activation, whether we're looking at relative to lymphocytic activation in the spleen or whether we're looking at tissue activation of dendritic cells. The point here is that medical intensive care septic patient who's got multiple comorbidities like diabetes that might, or say on cancer chemotherapy or other things, is actually going to have an impaired immune response. And the outcomes for those folks are actually a lot worse. And that's what this little graphic here demonstrates, is the kind of course, if you will, if you could draw it, which you really can't, so it's just idealized, versus hyperimmune versus hypoimmune. So here would be a young person, and the red would be a young person with an intense inflammatory response, in this case meningococcus, which really is a very potent stimulus to immune activation in somebody with a normal physiology. In the middle, we see an elderly patient. In the elderly, particularly elderly with malnutrition, you're going to see an impaired immune response, but still enough that they may get back and recover. But we take a diabetic with chronic renal failure and pneumonia, and they just sort of sag. And we've all seen these three different trajectories evolving in our septic patients, and it's really hard to turn these around. If you get on top of this and get the right microbial therapy for this young person, they're going to get better. They'll get off the vent in a couple of days. These folks are going to be on the vent forever, and and it's important if you're here, just recognizing the evolution of sepsis. If you have evolving sepsis and evolving ARDS related to sepsis, intubate them early. Don't wait until they have that hypoxemic cardiac arrest. Intubate them early, get on top of things, control ventilation, and then address the inflammatory components and appropriate antimicrobial therapy. This little graphic I put together just is based on stuff that you'll see out there in lots of different textbooks that relate to the mortality and the relative degree of organ failure that takes place. So it really points out the various impacts of the septic response. The circulatory failure in sepsis, we touched on that as we showed that slide of the microcirculation. That vasodilation through those channels that bypass the capillary bed results in hypotension, but it's a hyperdynamic hypotension. Now, early on, when we first start taking care of them, because of the capillary leak, they may have a significant component of hypovolemia. And if we get on top of it early, sometimes just volume replacement is enough to reverse the hemodynamics. But typically, more commonly, we give them lots of volume and the blood pressure doesn't come up, and then we need to add things like norepinephrine to support blood pressure in the circulation. This inflammatory response is mediated by a variety of factors: nitric oxide signaling, prostaglandins, interleukins, a whole variety of peptides like tumor necrosis factor alpha, and it results in a syndrome that's going to have relatively low filling pressures, a high cardiac output, and a markedly decreased SVR. And the mixed venous SAT, if they don't have too much of a hypovolemic component, the SATs actually may be high. Not at all unusual for mixed venous SATs to be in the 80+% range, which is normal's around 75%. They require usually large volumes of fluid to replace that volume that's been lost from the intravascular space. And it's also important to keep in mind that there's a significant percentage of patients with particularly gram-negative sepsis. There are peptides associated with the gram-negative organisms that have a myocardial depressing effect. So you can see a significant component of myocardial dysfunction. So you need to look for it and treat it appropriately. The respiratory failure in sepsis, again, it's the first organ that's hit by all this inflammatory stew. We get that alveolar capillary leak, and that's going to lead to progression. As that leak results in movement of proteinaceous fluid into the alveoli, we see hyaline membranes, and we see an intense inflammatory response. And that combination of edema, hyaline membranes, and the inflammatory response in the interstitium and alveolar spaces leads to a markedly decrease in compliance, but it also takes lungs which normally open and close nicely and expand and respond and makes them like tissue paper. So when we provide positive pressure ventilation, we see disruption of alveolar space and septae. And so one of the best things we can do for the patient with evolving sepsis and ARDS is to do a lung protective ventilatory strategy. That's actually one of the things that can make the biggest difference in terms of outcome. Renal failure in sepsis is very common, and it's multifactorial. It can be pre-renal because of that hypovolemia that I mentioned. It can be pre-renal related to hypotension and dilation and inadequate renal perfusion. And then finally, of course, it could be evolving ATN as we have tubular cell destruction and clogging of the tubules that leads to the insult to the kidney and renal failure and possible need for dialysis. Generally, that kind of ATN that we see associated with diffuse sepsis, if we manage the patient and the sepsis promptly, they come back. They come back pretty well. But we do have to be careful because during the process of trying to turn the septic shock around, they may be getting radiographic contrast, aminoglycosides. They may have a variety of things that can make the renal injury worse. So we really need to make sure we're not providing a iatrogenic component to that disease. The coagulopathy of sepsis is really a consumptive coagulopathy. So we wind up using up platelets and factors by virtue of microvascular coagulation. The little graphic here is from a classic study that was done on activated protein C by Bernard in New England Journal. It's referenced at the end. And just shows how activated protein C comes into play in terms of reversing some of this. But activated protein C is a normal circulating zymogen that actually has anticoagulant, anti-immune effects for the most part. And when we activate it, that actually impairs the consumptive coagulation as well as modulates the inflammatory response. There was a lot of optimism in the early 2000s about it as a potential, to decrease mortality significantly in septic shock. It really didn't pan out, and it actually increases bleeding. There's two forms, Drotrecagon, and I forget which company is which, and Zygris. Zygris was actually pulled off the market, and Drotrecagon's still out there, but not used much. You have to be really careful in the post-surgical patient as they can bleed significantly with this. So it depends a lot on the individual cause of sepsis. The gastrointestinal injury in sepsis is multifactorial. In our SOFA score, we look at the bilirubin, that the liver impact, the shock liver component. But understand that when we get a shock syndrome, the first thing our body does is restrict blood flow to the gastrointestinal tract. And so ischemic injury of the GI tract because of the splanchnic, and those splanchnic means the blood vessels to the GI tract. The splanchnic vasoconstriction can actually literally result in end organ damage. So what we see here depicted is a duodenal ulcer that's evolving by virtue of gastric hypoperfusion. But you can also see in the intestines, what we see here is a little graphic that shows the villi projecting up into the intestinal lumen. We get ischemia here, we get breakdown of the epithelial layer, and then bacterial translocation that results in an intense inflammatory response. So that translocation and gastric erosions are the epithelial component of the gastrointestinal injury. And then shock liver, elevated bilirubin is the hepatic component of that response. There's been a variety of biomarkers that have been looked at sepsis. The two that are most commonly used are C-reactive protein. It's an inflammatory reactant that's produced by the liver, and it's got a relatively long half-life. So when we have an initiation of an inflammatory response, it pops up and stays up. So it's been used to track sepsis and track response to therapy in sepsis. Procalcitonin, and I have no idea how calcitonin, which has to do with calcium regulation, as you can tell from the name, would necessarily be impacted by sepsis, but it is. And so procalcitonin does go up, and it's actually one of the more reliable markers for septic shock. Usually this diagnosis is easy enough to make from the clinical things we've talked about that you really don't need these markers, but the markers have been used to sort of grade the severity and assess the response to treatment. So you'll hear talk about them. Another one that you'll see out there is the arterial to venous CO2 content. That's less predictive than the other two, but we do tend to see more of a gradient between venous and arterial CO2 in patients with septic shock. But that's true in pretty much any hypoperfusion situation. So our management of sepsis now, sort of move into how we take care of it, finish things up here. There's been intense discussion about early goal-directed therapy. I'll get into that, and we're going to spend a lot of time on that in our discussion forum. So I'm not going to focus too much here because we'll get into it there. But I can tell you right from the very beginning There, other than protecting the lungs and managing systemic perfusion and hemodynamics, the most important thing we can do is getting early appropriate antimicrobial therapy on board, identifying the source of sepsis, culturing it to get on the right antimicrobials, and also, when possible, draining. So if it's a surgical collection of mediastinal pus, if you drain that, they get better. So recognizing the source of sepsis is really important in getting on top of it and reversing the overall process. Probably the best thing we can do besides our supportive therapies. I'll talk about all the variety of things that have been looked at, like we already mentioned activated protein C. We'll talk about corticosteroids. There's some things you can do to fine-tune therapy and maybe improve outcomes a little bit. But all of the targeted immunotherapy angles have not worked. And that's what this slide is. This basically shows a whole variety of individual interventions in the immune cascade. You remember, there's cellular involvement with neutrophils, macrophages, dendritic cells, lymphocytes. There's the cytokines that are elaborated and their response. So it's a big stew with lots of ingredients. And what this slide basically points out, the take home of this confusing slide I put together, is that none of these individual targeted therapies has worked. So we've looked at a variety of things. Corticosteroids, we'll talk about those. Replacement doses do seem to decrease mortality. They're flipping again. The hemofiltration to remove endotoxins with endotoxin absorption has, in some individual studies, been shown to be useful, but usually by the time it's done, the damage is done. So it's like closing the barn door after the horses have escaped. A whole variety of antioxidants have been tried without individual success. Cyclooxygenase inhibitors, interleukin-1 receptor antagonists. There's some new work with interleukin 6 and 13. That's still not, and physiologically it makes a difference. And so the thing is, any of these anti-inflammatory interventions, if you gave them all early enough, you might make a difference. But that means that you have to recognize the clinical syndrome early enough to intervene in the immune response and prevent it or modulate it. And the reality is, by the time we make the diagnosis, the damage is done. And that's the take-home message for all these interventions. All right, which brings us finally to Dr. Emmanuel Rivers and the early goal-directed therapy. This was a classic study that came out in 2001 in the New England Journal. Dr. Rivers is an ER doc, and this was done in Detroit in an inner-city hospital in an emergency room. So it's the patient population, and it was just one study in one center. So the patient population was really sick. And the kind of socioeconomically deprived patient who doesn't come to the intensive care unit or to come to the ER until it's pretty much end stage. So they were really sick. And he found that if he started this protocol of early goal-directed therapy that included early intravascular volume support, hemodynamic support, blood product utilization, transfer to the intensive care type therapy, that placement of a central venous catheter that would measure central venous SATs as well as provide CVP information. Doing all these things, he reduced mortality significantly from like 45% to 35%. However, so there it is, 30 to 40. He reduced it to 30% from 45%. So huge improvement. But this came under tremendous scrutiny because the eye in this PICO was like 6 or 7 different things that he was doing. So it wasn't clear exactly which particular intervention was making a difference, if any. And to make matters even worse, Dr. Rivers was taking money from the CVP company. He's a good guy. I've talked to him. I think that was just part of getting funding for his research, but nonetheless, it was a little clouded by that relationship. And that was actually one of the early. It's an early study that prompted all of us to be very cognizant of our potential um, secondary benefits, if you will. So the whole bunch of different multi-center trials were put together. It took a while for them to come out. They all came out in 2014 and 2015 in the New England Journal. And there was one done in the U.S., one done in Australia and New Zealand, and one done in England. And they basically demonstrated. What was interesting, if you look at these studies, and I don't want to cloud. We'll look at these in our discussion forum. So I don't. I really like you to look at them and for you to decide what differences there really are. But they basically essentially said no benefit to early goal-directed therapy, but the reality was they were kind of already doing it. So take a look at those. We'll talk about that in our discussion forum. A couple of other interventions that do seem to show a little benefit. I mentioned in our last lecture that in circulatory shock that has to do with sepsis and cardiogenic shock, that the response of the body in terms of vasopressin secretion from the posterior pituitary is not what it should be, not as robust. It's elevated, but not elevated as much as a normal person who is hypotensive. And so replacing low dose background levels of vasopressin seems to increase blood pressure, urine output, improve renal function, and decrease the need for other vasopressors. You do have to be careful anytime you're using vasopressin because it can cause intense vasoconstriction to the point that you can get coronary ischemia and intestinal ischemia. But that's usually with doses that are much higher than that 0.03 to 0.04. Usually doses 10 times that are the ones that can cause ischemia. Ventilation strategies, multiple studies. This is one of the earliest ones by Eisner, but multiple studies demonstrated that a lung protective strategy for ventilation improves outcomes and reduces mortality. So just like with the yards net, it's really about the same, and so that's important to do. The activated protein C, drotrecagon and Zygris, that sort of that peptide, that protein C that inhibits the coagulation response and the immune response, was shown in early studies to lead to earlier restoration of blood pressure, decreased mortality, but in subsequent studies, and there were several subsequent multi-center studies, it's been shown to actually increase mortality related to bleeding complications. The early enthusiasm for this in the early 2000s has pretty much been replaced, and so it's an intervention I might use in a really young person from like meningococcus or other types of bacterial sepsis who's having an intense inflammatory response, and DIC. That would be the setting in which I might use activated protein C if I used it early. Steroids and sepsis, there have been so many studies of steroids and sepsis, low dose, high dose, mega dose. The bottom line is this, that septic patients in general have less of an increase in cortisol than you would see with the same degree of hypotension in an otherwise intact person. And by virtue of that observation, Anane and others, but his study in 2002 showed that not just the glucocorticoid, but the mineralocorticoid. So hydrocortisone is the glucocorticoid, fludrocortisone is a mineralocorticoid, and that using those in low doses decreased mortality. He subsequently did a systematic review of a whole bunch of studies and showed that basically putting them on low-dose replacement therapy, so not the anti-inflammatory high-dose corticosteroid, but just replacement therapy, does seem to improve outcomes. So that is something to think about doing in your patients. Tight glucose control got a lot of attention early. Dr. Vanderberg, originally she's a gal from Belgium, I think, or Netherlands, and she original studies were done in cardiac surgical patients. So she was, and then general surgical patients. When she extended it to medical intensive care unit patients, and that was the nice sugar study, there really wasn't much benefit, and there was more hypoglycemia and stroke with tight glucose control. But I think in the surgical patient, it does make a difference. And I was very much involved in doing protocols for tight glucose control for cardiac surgery patients, and I think we made an impact based upon her earlier studies in that subgroup of patients. In the general medical ICU type population, probably not so much, but there's a whole variety of reasons from lab studies, physiology studies that would show that better glucose control might be beneficial. Those are at the top there, but the reality is the clinical application never quite panned out. So our bottom line is early goal-directed therapy probably improves and saves lives, maybe as much as a 25% decrease in mortality. Lung protective ventilation, definitely. Activated protein C, maybe in non-surgical severe sepsis in young people that have DIC. That's pretty much it. And the most important thing we can do is get early appropriate antimicrobial therapy on board. So we need to identify the source of sepsis, drain it or treat it as we can, and then provide for multi-organ support by maintaining O2 delivery to the tissues and perfusion of the kidneys. And that's what we can really do to impact outcomes in septic shock. So there's our references. There's a bunch more that are in your articles that are loaded up on Blackboard. So hopefully read those and you'll get a broader view of this. But this should help you not only in developing your care plan, but also in your discussion forum for this module. Any questions, please feel free to email or call. You know how I love to talk to you and enjoy it. So I'm here. Give me a buzz. Particularly if you have after reviewing this and you have an interaction with the septic shock patient in your environment and things go better, tell me about it. I like to hear that kind of stuff. All right, take care. I'll talk to you soon. Bye.